Hi, and thank you for taking time out of your day, evening, weekend, whatever it may be, to spend a little time learning a little bit more about practical stroke management in the pre-hospital setting. I know you may kind of have the position or the thinking that, I know everything I need to know about strokes, maybe so, but I do think there's going to be some things in this video that are eye-opening and different than you may have heard before related to stroke management. The key thing here to keep in mind is that regardless of best efforts, stroke isn't going away. We continue to see a rise in stroke patients. For many of us, we may actually interact with and deal with possible or actual stroke patients more frequently than we do with, say, cardiac situations. So having a good handle, a really, really good handle on how to manage stroke is really important to us. Also, it's important to understand that your actions and decisions as an EMS provider, whether you're EMR, EMT, AEMT, or paramedic, really do make a tremendous impact on the aftermath of a stroke for a patient. And so I think we understand that tangentially, but one of the goals here in this presentation is to really drive that point home and demonstrate to you actually how you, in the pre-hospital setting, have a very, very dramatic impact on that patient's longevity and outcome. So with that, let's talk a little bit about the key objectives of this presentation. First of all, it's to improve our overall skills in effectively dealing with a stroke in the pre-hospital setting. I really want to hopefully arm you with some practical skills, algorithms. I know many of you may be familiar with stroke scales and things like that. What I have found is a lot of these things start to fall apart when you have family members who are crying and concerned, and you've got maybe police officers asking questions, and you've got other people in your unit that may have not dealt with stroke before, and you're trying to assess a patient. So we're going to talk. I'm going to present to you a means of dealing with all of that, hopefully very effectively. We also want to make sure that this program is appropriate for EMRs, EMTs, and paramedics. Regardless of your level of certification, chances and the reality is that you're going to address stroke in the same way. We'll talk more about that in a little bit. The critical success factor of this program is to help reduce the amount of time it takes you to evaluate the patient and to get them to the appropriate level of definitive care. Now, there's a lot wrapped up in that, right? What we want to do is have an approach that is evidence-based, but ultimately lets you make a decision as to, do I need to get this patient to a primary stroke center, a comprehensive stroke center? Am I even dealing with a stroke, or am I dealing with something else? And since time is really the biggest factor in dealing with strokes, we need to really find a way that our skill set is foundationally very sound, and we can help do everything we can to reduce that decision loop, right? If we were thinking about this from a military or a tactical perspective, we'd be thinking of something called ODA, which is where we observe, orient, decide, and act. Or orient, observe, decide, and act. So either way, the idea here is let's figure out if we can reduce the amount of time it takes for us to get to that decision as to what we're going to do with this patient. The other thing is that one of the things we've seen and observed in stroke management in the pre-hospital setting is that we're very focused on the assessment, the severity, the stroke scale, but there's other information that is extremely important that has to be given to the stroke team at the hospital. And if they don't have that information, it's again going to waste time, because now they have to go get that information from a family member or someone else. And if that isn't available, they're going to be guessing at what their treatment options are. So again, one of the things here to keep in mind is you play a very vital role in providing the foundation for definitive care. And if you don't do your job correctly, it really hinders that patient's ability to get that definitive care in a timely and effective manner. So everything in this presentation is evidence-based. These are the sources. There are some other sources that I drew upon. Hopefully this is the latest information. There are some nuances. Obviously there's a variety of different stroke scales, and people have their own approach to doing a stroke scale. There's no one right or wrong stroke scale. Obviously you should go with your local protocol. We are going to be talking about the BFAST plus stroke scale in this presentation, but you can substitute this or that with whatever stroke scale you use for local protocol. So pop quiz for you. how many different types of strokes are there? Most of us, probably are either EMR, EMT. You probably can reach back and think about, how many stroke types? What are the different types of stroke categories that there are? So, choose an answer here. Is it 1? Is it 2? Are there 3 different types of stroke? 4 different types of stroke? 5 different types of stroke? What do you think? All right. So hopefully you have an answer. The correct answer is 5. 5 different types of strokes. So let's walk through these different types of strokes and categories. I know some of you are, what? That's not right. You're already proving to be a nut job. I know, but just bear with me. Okay, so the types of strokes, the 5 types, based on the latest evidence and the latest research that we have, are here on the screen. And most of the top 3, the ones in the first 3 you see on the list, are probably what you're most familiar with, right? An ischemic stroke, these account for about 87% of all strokes. This is where we have a clot. A hemorrhagic stroke is where we have a vessel burst. Right? It's typically uncontrolled blood pressure, uncontrolled hypertension is what is going to be the leading cause of a hemorrhagic stroke. So right here and now, we can try to determine if we're dealing with a patient and we're trying to distinguish the stroke type. One important question to ask is, what is the patient's blood pressure? Are they taking anything to control high blood pressure, hypertension? And if they are, this may give us an indication that we're dealing with a hemorrhagic stroke. So, when we talk about assessments, there are some things we need to do even before we get into the actual stroke scale assessment, right? And understanding, is this patient on any type of blood pressure medications a critical thing to understand. A TIA, a transient ischemic attack or a stroke, obviously we know that this is a temporary stroke, right? There's probably been some stroke activity, a clot of some sort, certainly not hemorrhagic because we wouldn't see that, but there's been a clot and the clot somehow broke apart or lost its ability to inhibit blood flow. But for some period of time, while the patient was having symptoms of a stroke, we did have that clot, and it resolved in some way, shape, or form. This is considered a warning sign of bad things to come, right? So we still need to get this patient to the hospital, and we still need to monitor them closely, but they're not having a stroke in our presence, right? Not a full-on stroke. The next 2 are the ones that are probably newer or new classifications or newer classifications to you. The first one is a cryptogenic stroke, and this is where we cannot determine why the stroke occurred. We'll talk about that in a little bit, and that will give us some hints into what we need to be asking and thinking about. A brainstem stroke is a stroke that occurs, or a clot that occurs in the actual brainstem and creates what's known as a locked-in state. And we're going to talk a little more about locked-in states. Simply stated, if the patient cannot move any extremity below the neck, then we probably have a patient that's in a locked-in state. They also may not be able to speak to us, but they can't move either side, right? Typically, we're looking at one side or the other for a stroke. And many times with a brainstem stroke, we're seeing no ability to move anything below the neckline. And we'll talk more about how and why that occurs. But I think it's important and hopefully eye-opening right from the get-go here that most of us believe there are 3 types of strokes, and yet there are 5. And secondly is the type of stroke can help us start to think about the questions we should be asking. If we understand the types of stroke, we can think about what we need to know, what we need to ask, right? And even right now, we're walking away from this just knowing we really need to think about, does the patient have any uncontrolled or history of hypertension? So when we talk about the most familiar types of strokes, it's this, right? This is what we're typically taught in EMR, EMT school, and maybe even in some of our paramedic training. But as we get into more advanced management of stroke and really start to understand the physiology, anatomy, and response and research to stroke, we see that there are other types of strokes we've mentioned. But let's just briefly think about the 3 that we have, right? So ischemic, simply obstructing a blood vessel. Basically, we're cutting off that oxygen supply to the brain. Right. And if I asked you from a trauma perspective, how long can someone last without blood flow, or a CPR cardiac perspective, how much can someone last without blood flow to the brain? We'd probably say 3 to 4 minutes, right, before we have irreversible brain damage. So this is where we need to think about when we have an obstruction. We may not have a full obstruction of all blood to the brain, but we have a challenge here because some part of the brain has been obstructed, which is going to lead to potential irreversible damage. And that's why we're up against this clock. So the second type, hemorrhagic stroke, this is the most difficult stroke to deal with. But this is where we have a rupture in the vessel, right? We actually see a hole has been created in a vessel, and the person's basically bleeding. And this is a very challenging situation for us as EMS providers. And then lastly, we've talked about this, TIA, transient ischemic attack, mini stroke, warning stroke. We have a situation where there's a temporary blockage of blood flow. I know I've already mentioned this. We're going to go into it just again. I want to make sure we're all very comfortable with this. And you probably should be if you've gone through any EMR, EMT, paramedic, nursing training. This is all very basic, but it's always kind of good to revisit the basics, especially from a different perspective. So this animation here really kind of shows us what happens with an ischemic stroke, and it occurs over time, right? So we may be looking at patients, and I think this is important. Are they a smoker? Do they have COPD? Do they have history of cardiac issues such as arteriosclerosis? Do they have potentially diabetes? All of these things, right, can help us create clues as to, are we dealing with an ischemic stroke? This is really also important with a TIA. When you have a person who's got a transient ischemic attack, often they don't want to go to the hospital. They feel fine. It was just something passing. Maybe it's something they ate. Who knows what excuses they're going to bring up. But understanding their history can help you get them to understand that, you're probably headed for a major stroke. We need to get you to definitive care so that we can figure out what's going on. And the only way we're going to figure out what's going on is imaging. Right? We need to get an image of the brain. So I think it's important for us to visually understand what happens when an ischemic stroke is being created, right? And I think this video, this image here, helps us to kind of maybe get that graphic in our mind and revisit how this occurs. Okay, so we have some clues now, at least TIAs, right? If we have somebody actually having an ischemic stroke, the historical background around diabetes and things like that is somewhat important, but we're going to deal with some other things as we go through this presentation that take priority to getting a full medical history. Hemorrhagic stroke, I think, is also kind of having a visual as to how this occurs is critical, right? This is a very immediate, as you can see, right? It's sudden onset, very immediate, very painful. There are some precursors to the actual bursting of the artery that we will talk about. But ultimately, it's just the arteries burst. And this is a very, very serious situation and often going to be fatal. But there's some things now happening in the stroke centers that can help address this potentially, depending on where this has occurred. So we don't really know where the hemorrhagic stroke is occurring in the pre-hospital setting. So again, we're racing the clock. Right, and we're going to keep racing that clock over and over throughout what we do here. So a cryptogenic stroke, this is probably something you may have not heard about before, but 1 in 3 ischemic strokes are actively cryptogenic. So cryptogenic basically means we don't know why this person had the stroke. We don't have a very serious cause and effect. And so we need to kind of look at potentially hidden factors, some things that can give us clues as to why this stroke occurred. Now, in most cases, we're not classifying strokes in the pre-hospital setting. It's very hard for us to do. We're looking at symptoms, and we're going to make decisions based on those symptoms as to what definitive care we need to get to this patient. But I think some things to keep in mind here is that cryptogenic strokes occur at a higher incident in African Americans and Hispanics. So this is really important. The other thing, and this is kind of some of the clues in terms of when we're thinking about stroke assessment, is patients with AFib are 5 times greater risk for stroke. Things like a hole, patent foramen ovale, probably didn't say that correctly, but basically it's a hole between the in the heart, right, between the chambers. That didn't seal properly when the person was born. If they have that condition, they're a higher likelihood of having a stroke. And the epidemiology and physiology behind that are really fascinating. We're not going to get into that right now, but knowing if the patient has had a birth defect that included a hole in their heart or would be important to know. And obviously, hardening of the arteries. Now, we're not talking about neurovascular here. We're talking about cardiovascular arteries, and then any kind of blood clotting disorder, right? Does the patient have something like latent factor V issues and things of that nature? So again, we're not trying to, in this case, classify the stroke. That's not our job in the pre-hospital setting. What we're trying to do is learn about the different types of strokes so we can think about what questions we should be asking, right? So important here is, does the patient have AFib, a history of AFib? Does the patient have a birth defect related to the heart? Does the patient have a history of atherosclerosis, diabetes, hypertension? Are they on blood thinners? All of these things are critical because as we gather these details, we're going to be able to help the stroke team at the hospital make decisions. And if you don't have this information, as I mentioned, it's going to delay treatment. A brainstem stroke, very complex symptoms, and they can be extremely difficult to diagnose. They can present themselves, as any stroke can, as something very different. So we have to be very careful about how this is being interpreted. If we can't rule it out, maybe the best thing to do is consider that we have a stroke, that's a brainstem stroke. And so there's a few things that we can think about, and these are going to probably be things we don't remember under stress, so it's important we revisit this over and over. A brainstem stroke typically is going to have somebody who has vertigo, right? The room is spinning, they're dizzy, they feel dizzy, and they can't maintain their balance, right? They have a severe imbalance, they can't stand, right? So their room is spinning, they're kind of dizzy, they may faint. They may recover from the faint and imbalance. But the important thing here is we have to have those three things: vertigo, dizziness, and severe imbalance. And they won't probably have weakness on one side of the body. This is kind of the telltale sign. So most strokes, you have weakness on one side of the body, the other. With a brainstem stroke, you're going to typically have these three things. Now, important here, I highlight on the side, it's not just dizziness. If somebody's just dizzy, it has to be the three things. We're looking for vertigo, imbalance, and dizziness. Now, the one caveat I will tell you is these things can develop at different rates. So you may have somebody who's dizzy, suddenly starts to develop vertigo, and then becomes imbalanced. Or they're imbalanced, they get vertigo and dizzy. So those three things, think about them as a triangle, and we need all three to classify it as a brainstem stroke, but they can they can present themselves in a different level of time frame. The big telltale sign, the big thing that really is like, yep, we got a brainstem stroke here, is what we call locked state. This is where the patient can't move anything below the neck, as I mentioned earlier. Again, we're trying to learn from the categories of stroke, not diagnose the type of stroke. Ultimately, the definitive diagnosis of the type of stroke, and even if a patient is having a stroke, will be done at the stroke center. And they will do it with imaging. There's no doctor that's going to look at someone and say, yep, you're having this, right? You can kind of guess at what they're having, but ultimately all we're trying to do, literally all we're trying to do is figure out, are you having a stroke or not? And you're going to see in a little while, we're just trying to determine, do you have a TIA or not? I'll explain that in a little bit, and it's a little bit different thinking than probably most of you have ever been taught before. So let's get into some stroke symptoms and treatment, and this will help us drive kind of our ability to manage, right? So I'm not going to go too deep into this because I try to teach from the perspective that under stress, we as the provider can become hesitant in action. And in a stroke, we can't become hesitant. We need to really take definitive action so we can get people to definitive care. So yes, we're going to have slurred speech, we're going to have weakness, we're going to have left-sided neglect, right-side preference. We may have speech problems instead of slurred speech. We may have problems with comprehension. The important parts here to think about is, if we see any of these, we have a stroke. Now, whether it's right-sided or left-sided is important to kind of understand if we can, But more importantly is collecting the symptoms and just getting to that decision point that we have a stroke, right? At that point, we know that we have to start the clock and get this person to definitive care. The brainstem stroke, we've talked about some things that can give us hints as to, as this happened, there's some additional symptoms we may see, like nausea and speech problems. Well, why is this occurring? Well, the reason this is occurring, right, if we go back to our little diagram, is because ultimately a brainstem stroke, there's a blockage of the vascular, right? The stroke has occurred in the brainstem, and the vascular structures of that brainstem. And so we're cutting off that oxygen supply to the rest of the brain. We're shutting down the brain. This is, again, a very serious situation, much like hemorrhagic, and is very difficult to deal with. So we're going to see some additional symptoms, but that lock state, that combination of dizziness, vertigo, and imbalance, are kind of our telltale signs, right? And you can kind of think about the fact that, hey, nausea and vertigo and these things don't appear in right-sided, left-sided strokes. Typically, we're looking for gaze, neglect, weakness, one-sided weakness, things like that. Hemorrhagic strokes, we can see intracerebral or subarachnoid. Again, we have a hard time differentiating. Now, we can say if somebody has nausea and vomiting with a headache, we're probably looking at intracerebral. And again, we may have that one-sided weakness, that decreased consciousness. Why? Because we've decreased oxygen flow, because the person's leaking blood, right? That's basically what's happening here. Now, with intracerebral, it may be a slower amount of blood loss, and we have some time. With a subarachnoid hemorrhage, the person's going to report the worst headache of their life. Now, here's something to keep in mind: is this may come from a family member. We need to ask a family member or bystander, were they complaining of any type of headache prior to the stroke symptoms. So with the hemorrhagics, we are going to find that they're also going to have some type of additional stroke symptoms, right? We're going to possibly see the one-sided weakness. We're probably going to see the decreased consciousness. We may see some things. The important part here is we need to consider that this is a stroke until we rule out that it's not a stroke. Right. Obviously, if we have head trauma, if we have some type of fever that was present beforehand, we may be looking at something different. But if we can't definitively figure that out, we're going to go with it's a stroke until we rule out it's not. There's some things that obviously mimic strokes. Two of those we can kind of clear up pretty quickly. Drug overdose or poisoning, we can either figure out very quickly through pupillary size, environmental surroundings, and family member or bystander information. And if we have one of those, then we can treat accordingly. Hypoglycemia, depending on where you are, and if you can take blood glucose levels, we can determine that, as well as history of the patient. Are they diabetic or not? Did they eat? Those type of things. So we can see stroke-like symptoms, but in most cases, we're not going to be able to make definitive differentiation, right? So if I told you that somebody had a brain tumor, or you didn't know they had a brain tumor, you're not going to be able to do much. And if they have a brain tumor and they're showing stroke-like symptoms, you're still going to treat it as a stroke until a higher level of care, definitive care, decides they're not going to, right? But on our level, as regardless of EMT, EMR, paramedic, we're going to treat most things as stroke until someone tells us not to treat it as a stroke, except for drug and hypoglycemia. Now, one thing to know is that blood glucose levels are critical to understand in stroke patients. In fact, the sooner you can get a blood glucose level, which for many EMTs, that's not possible due to local protocols, but this is one thing paramedics can really help with, is, in some jurisdictions, AAMTs, is getting that blood glucose level. There's a lot of research that is showing that blood glucose levels and understanding them from the stroke onset through definitive care can make a difference, especially in terms of how we manage that patient long term, and can also become a predictor of the long-term outcome of that patient. Also, helping manage the blood glucose level, getting those glucose levels up if we can, is very important to maintain and support cellular activity. So just something to know that even though if you're dealing with somebody that's hypoglycemic, they may very well be having a stroke. So even if you have somebody with diabetes and they're showing hypoglycemic symptoms and stroke symptoms, you should still deal with this as a stroke. And depending on your level of certification, local protocols, you may decide to address that hypoglycemic state in some way, shape, or form. Obviously, one thing I will say is you're not going to give someone glucose orally if they're suspected of having a stroke. Your chances of them being able to swallow are going to be very low, and you're going to complicate matters. So just thought I'd throw that in there. So the chain of survival here, right, is basically, family member or bystander witnesses or sees the stroke, calls 911. And then the two things that we're really responsible for is performing that stroke assessment as soon as we get on the scene and rapidly notifying the receiving hospital. And we're going to talk more about that and how we carry that out very shortly. So if we have an ischemic stroke, there's a series of different types of, there's an algorithm that goes behind this, right? Are we less than 3 hours? In some cases, 4.5 hours, depending on the patient. But we're just going to call it 3 hours. We don't need a lot of complication in our world, in the pre-hospital environment, like, well, is it 3 hours or 4.5 hours? We're going to focus on that 3-hour window. We want to get that patient to the definitive care within 3 hours. That's our standard. It should be. 4.5 hours, that's a cop-out. It's too much to think about. If it's greater than 3 hours, then we may consider other treatments. But again, let the stroke center figure that out. We're just going to get the person to the stroke center. Ultimately, depending on what happens, the patient is going to get imaging, and then we're going to start IV thrombolysis unless contraindicated. We'll talk about contraindications on thrombolysis in a moment. So here's the thing, right? We basically have two options with stroke patients. We can do medical management, right? Get them within 3 hours to some form of definitive care, and they're going to start TPA, right? IV, which is a clot-busting drug. There are some contraindications that I just mentioned. We'll talk about those specifically. The second thing is mechanical thrombectomy. Now, the thrombectomy, we have up to 24 hours. But for our purposes as pre-hospital providers, we want to get people to that definitive care within 3 hours from time of onset. And frankly, even if time of onset's beyond 3 hours, we're still going to try to get them to definitive care, right? We're not just going to leave them at home or wherever we find them. So ultimately, get the patient to definitive care. So, let's see. We're not going to get too big into this, but I want to talk about contradictions to thrombolysis. One is we need to know, has this patient had a stroke within the last 3 months? If they have, they may not be a candidate for thrombolysis. Have they had recent head trauma? By recent, we're talking the last, say, 72 hours or so. Have they had any recent surgery? Now, here we're talking about intracranial, intraspinal surgery, but we really should classify this as any recent surgery within the last 90 days. Intracranial hemorrhage, is there any history of this, which could be due to cancer or tumors or something else? Is there any GI bleed? Is the patient dealing with any kind of blood clotting issues? Are they on heparin, or have they been recently on heparin within the last 72 hours? Are they taking anticoagulants for any kind of blood clotting issue, right? Are they on blood thinners of any sort? Is there any type of suspected aortic arch? Do they have hypertension? Are they older than 75 years of age? 75 years of age is typically a contraindication for thrombolysis. Now, the reason I'm bringing all this up is this is going to be very critical as we talk about what type of stroke center we go to. As you can see, there's a bunch of reasons that you can't give thrombolysis. Now, some of these are relative, such as the age. The physician may decide to give the IV, the TPA anyway. And in some cases, the physician may not, because there are complications with that. When we can't do this, then we kind of have to go back to mechanical thrombectomy. And so this kind of starts to play into where are we taking this patient based on us understanding the contraindications. But gathering these contraindications is critical for us to pass on to definitive care, because they need to, the last thing we need to do is get the patient to the hospital, and then the stroke team has to go figure all this out. And hopefully they can get a hold of somebody to ask all these questions, because we didn't do our job and figure this out before we left the scene. I want you to pay attention, and these slides here, these come right from the American Stroke Association, so this is the education from them. If you look over here, you can see EMS identifications of current medications, especially anticoagulants, and obtaining patient history, including comorbid conditions and family contact information is critical because it may impact treatment decisions. This is a critical thing. This is the one piece I think we don't do a good enough job teaching in EMR, EMT programs, is that, hey, yes, you got to get the stroke scale. In most cases, you are going to just observe that the person's having a stroke without even having to do a stroke scale. I'm not saying not to do the stroke scale, so chill out for a moment. But what happens is we get caught up in doing this stroke scale, and we're not asking pertinent questions, right? We're not going to do a full medical assessment. We're not going to go through sample. We're not doing DCAPS, BTLS unless we have some MOI or NOI discrepancy. But in most cases, if we observe someone and they look like they're having a stroke, we're going to need to get this abbreviated information. All right, so let's talk about assessment and response, right? First thing we need to understand is basically there are two types of stroke center. There's actually a couple more, but for our purposes, we're just going to say there's a primary stroke center and comprehensive stroke center. There's actually a type of stroke center that's in between the two of those, but we're just going to kind of focus on these two. I'm not going to go through all of this with you. You can pause the video, which I suggest you do, and understand what a primary stroke center can do versus a comprehensive. Long and short of it, this is how I look at it. A primary stroke center does not have neurosurgeons and an operating room staffed 24/7, right? They may have a stroke team that's there 24/7. They may have imaging capability 24/7. But the comprehensive strokes team center is going to have every resource they need at the hospital. We're not calling somebody in from some other location to come in and deal with this patient. In fact, there are some programs now where actually they do a reverse medevac, where if you take a patient in rural areas to a primary stroke center and they realize they can't support that patient, they'll fly the doctor and the neurosurgical team to that hospital to perform the surgery versus flying the patient to the comprehensive stroke center. In most cases, what's going to happen is if you take a patient to a primary stroke center and they can't deal with it, then they're going to transfer the patient to the comprehensive stroke center. So one of the questions you need to ask, this is your patient, is based on what you are seeing and you're collecting and your powers of deduction here, is it just better off to take the patient right to the comprehensive stroke center? That is ultimately the biggest question you will have when you're dealing with a stroke patient. And from my experience, it is get this patient to a comprehensive stroke center, except in one scenario. Now, when we're thinking about getting to that, whatever stroke center we're going to go to, obviously we need to think about potential impacts in our travel. We need to think about traffic patterns. We need to be thinking about weather. Is it snowing? Is it raining? Are we dealing with flash floods? Are we dealing with seasonal traffic issues where we can't, we may have an influx of traffic because we live in an area that, has chronic backups and traffic congestion? Is it rush hour? Where are we dealing with? Are we in a rural area that, on a good day, we're talking about 45 minutes just to get to any hospital versus a comprehensive stroke center that's 90 minutes away? The reason I want you to think about this is that based on your calculation of how much time you have to get to a primary or comprehensive stroke center, and what your patient needs, right? Like if your patient needs a comprehensive stroke center, and that's really what they need, you may need to consider medevac. I think a lot of times we don't think of medevac for a stroke patient. We think about it for trauma and burns and things of that nature, right? But if you have a patient, medevac is for anything that is time dependent. So you need to really think about how much time do I have? I have a 3-hour window. You've probably chewed up a bunch of much time between the time you were patient was discovered and your arrival, and then your assessment, and now your decision point for transportation. And then how much more time is it going to take you to get to the primary or comprehensive stroke center? And if the patient really needs a comprehensive stroke center, again, how much further is that away from where you are? So do not rule out medevac for a stroke patient. Now, obviously, in doing this, you need to think about how long will it take medevac to get to you, and then transport time from you via medevac to the stroke center. But you need to make this decision. It's a very important decision. To help you make the decision, here's what we're going to do. You have this algorithm. This comes from the American Stroke Association. Now, I'm going to augment this a little bit to make it even easier for you. So what they're basically saying, in a suburban area, all right, and they have 3 algorithms, one for rural, one for suburban, and one for urban. So we're going to go down the middle and just use the suburban transport recommendation. What they're saying is if you have an LVO stroke suspected, right, a large vessel occlusion stroke suspected. So what's an LVO? We throw that term around. Typically, that's going to be anything except a TIA. Since we really can't look inside somebody's body, right, unless maybe you have POCUS, point of care ultrasound, which would be awesome if you did. But even with that, chances are you're not going to be able to determine, is this a brainstem, cryptogenic, ischemic, or hemorrhagic? The symptoms may lead you in a direction, but any one of those, right, brainstem stroke, cryptogenic stroke, ischemic stroke, or hemorrhagic stroke are large vessel occlusion strokes. Okay, they are some form of stroke that's the artery is either burst or you have a blockage in a major artery that's causing the problem, a vascular artery. So let's just go with this. Is this a TIA stroke or not? If it's not, then go to the primary stroke center, right? If it is a TIA, right, if you have a transient ischemic stroke, right, where the symptoms have cleared up, patient seems normal at this point, but they did report stroke-like symptoms for an X period of time, then get them to a primary stroke center. If you have anything other than a TIA, get them to a comprehensive stroke center, or what you see here is the one that's in between primary and comprehensive, which is a thrombectomy capable stroke center. In either case, if you have an LVO, chances are the patient will need a thrombectomy, right? And so we want to get them to where that can be done if it's needed. What we're saying here is you have 45 minutes max transport time. So let's talk about that. If you're in a situation where it's going to take you more than 45 minutes to get to the comprehensive stroke center, then go to the nearest primary stroke center, right? If you can do it within 45 minutes or less, get to the comprehensive stroke center. Again, medevac could be your friend here, and you need to think about it. So what we're really playing with here, after we do our assessment, we think about everything, is really we have to stop and think about how long is it going to take me to get to my patient to definitive care. And in my world, the way I look at this has the patient had a TIA? Yes, they have, right? So we don't have an active stroke. We're not looking at somebody who's actively stroking in front of me. They've got all the symptoms of some form of a stroke, ischemic, hemorrhagic, cryptogenic, brainstem. Then, if they're having a TIA or had a TIA, they're going to a primary stroke center. Other than that, if they're actively stroking, if I'm witnessing weakness, slurred speech, drooping, gaze, lock state, any of those things, worst pain in my life, I'm getting that patient to a comprehensive stroke center unless it's going to take me more than 45 minutes to get there. And the reason for that, just so we all know, is chances are if it's going to take more than 45 minutes, the patient's outcome is not going to be as good as we hope, and you need to get them some care. Now, all of this is secondary to any life threat. If you have a life threat, the patient's not breathing, patient stops breathing in your presence, patient goes into cardiac arrest, there's trauma, those obviously need to go to the appropriate closest definitive care, right? So hopefully this makes sense to you, and it gives you a little bit of way to guide your thinking, right? Patients had a TIA, get them to primary. Other than TIA, within 45 minutes, get them to a comprehensive stroke center. And that 45 minutes is going to be a judgment call for you, right? Okay, hopefully all this is helpful. So let's put together a stroke protocol, right? Something where we can just, every time we deal with a stroke patient, we're going to carry this out. So first thing is we're going to move. We get on scene, wherever that scene is. It's a restaurant, it's a house, it's an apartment building, it's outside, it's a park. And we've been told this patient's having a stroke. we're going to first and foremost obviously address any life threat. If we don't have life threats to address, or the moment we address them, we're moving the patient to the ambulance. I want to be very clear about that. We're not going to sit in the living room and take the patient through a stroke scale or in a park bench. Even if the person's had a TIA and they've reported stroke-like symptoms, or they have histories of strokes, then, ma'am, sir, you know what? I'd like to get you into my office. My office is the back of the ambulance. Let's just go in there. I have my tools. I can talk to you a little better. It's a little more quiet. I got a little better light to work with. Are you okay with that? Let's get the patient in the ambulance. If they're actively stroking, you can see obvious facial drooping. They're not responsive. Whatever it may be, get them in the ambulance. So our first step in a stroke situation is going to be address life threats and get this person in the ambulance, not perform the stroke scale. Hopefully that makes sense. Once we get them in the ambulance, we're going to evaluate and gather. So what does that mean? We're going to now do our stroke scale. So I'm going to talk about BFAST Plus, and you guys can do whatever you want if that's not your local protocol. And remember, there's no better or worse. Even the American Stroke Association says, hey, use whatever protocol you want, just get the evaluation done. So we're going to perform our assessment in our office. Our office is the back of the ambulance, right? And so why are we doing that? Because as we start determining the level of stroke we have, we're trying to fight that clock, right? So I don't want to go through a stroke evaluation and go, oh yeah, they're having a stroke. This one looks pretty bad. And now let's move them, right? If we're already in the ambulance, and we can now, in fact, depending on what we're doing and where we are, we can start moving the ambulance, right, and moving towards definitive care. And we're racing against the clock. So one of the things we're going to do is evaluate the patient, right? The second thing, we're going to gather information. We're going to get patient history and pertinent details. Again, we're not doing a full sample. We're not going to be doing all decap PTLS. We're not doing a SOAP. We're trying to get whatever. If we've determined this patient I have a high suspicion that they're having a stroke, I am going to gather what I need to be able to communicate to the stroke team and help them do their job more effectively. That's what I'm really focused on, okay? And I'm going to make a transport decision, which we just talked about. So if this person's talking to me and they're able to communicate and they've had symptoms of a stroke, that's TIA. If they can't communicate with me, then the stroke's ongoing, more than likely. They're going to primary stroke center. If it's anything else other than that, I'm telling my driver, let's start going to a comprehensive stroke center. And if my driver comes back and goes, you know what, it snowed 3 feet out, we're going to take 2 hours to get there, I'm going to be like, well, let's consider medevac, right? Okay. The other thing we need to do is prepare for crash, right? And this should be for every call, but stroke especially. This patient can deteriorate. We have a hemorrhagic stroke, brainstem stroke, cryptogenic, right? We may have a situation where the patient had AFib and, they suddenly crash on us. So let's get BVM O2 suction. If we're more of an ALS unit, let's get whatever, obviously we're going to get this patient on a monitor. We're going to draw blood for glucose. We're going to get vascular access. So we're going to start doing what we need to do to help give further information to the definitive care team, the stroke team, but also to prepare in case this patient deteriorates or crashes. We don't have to then go figure out what stuff we want to have ready. We're going to have all that stuff ready, connected to oxygen, connected to suction. We're going to have oxygen turned on. We're going to have, our suction systems all connected. We're going to have, all of that ready to go. Our BVMs connected, all of that, right? For BLS, we may have NPAs ready to go. If we're, an ALS unit, we're going to be ready to intubate as we need. So prepare, right? So far we moved the patient, right? We've evaluated and gathered, simultaneously we're preparing, and we're probably at this point moving towards the primary or secondary stroke center. Even if you have a TIA, you're going to prepare, right? TIA is a warning sign. We don't know how much time we have before the actual big one comes. It could be 6 months, a year, or it could be 30 seconds. So just because somebody's having a TIA, and I guess this is something good to talk about. If somebody's having a TIA and suddenly they stroke and go into a full-blown observed stroke, you may need to redo your transport decision and say, you know what, let's divert to comprehensive stroke center, right? This person just stroked out in front of me. And then we're going to intercept and notify. And for this is for those situations. We have 2-tier systems. You have BLS and ALS are separate. Obviously, if you're ALS, you don't intercept, you just notify. But intercept and notify is you're either intercepting paramedics or you're intercepting medevac. Right? So if paramedics are more than 4 minutes out, get moving towards the paramedics. And why 4 minutes? Because it should take you about 4 minutes to do number 2. Right? So you're going to do your BFAST plus, gather information from family and standby, probably in about 4 to 5 minutes, 6 on the outside. Okay, so if we think about 5 minutes to get the patient in the ambulance, 5 minutes, I'm giving you an extra minute to do your assessment and gather information. You 10 minutes on scene, get out of there, right? So we're not going to wait longer for paramedics. We'll intercept them. Now I want to talk a little bit about paramedics. There's not much a paramedic can do for a stroke. There are some research projects thinking about giving paramedics access to clot busters, but in most jurisdictions, we don't have that. So paramedics are going to really be about cardiac monitoring, determining do we see signs of AFib or some other heart arrhythmia that could have thrown a clot, and do we need to treat that AFib? And secondly, vascular access, right? Because we may see vascular collapse in a patient with a stroke, and so we need to address that and try preserving vascular access. But we're not going to be starting to give fluids. There's no drugs we can give. We're not going to really do pain management. We're not going to intubate, right? They're there in case the patient deteriorates further. So we need to think about that is waiting for paramedics, you're just hurting the patient. Get moving towards your stroke center, right? Whichever one you're deciding to go to. You need to notify the stroke center, right, that you're coming. They need to activate their stroke team, especially a primary stroke center. They're not just sitting around. Comprehensive stroke centers may have specialized stretchers, teams, people all just kind of sitting there waiting for that stroke to come in. But you still need to notify them. And when you notify them, there's going to be certain information you have to give them. To do that, we put together the stroke assessment template for the agency I work with. And one of the decisions we're making is to have this as part of every stroke call we go on. And this will probably get updated over time. But this is kind of what it looks like. And basically what you have is, and this is something new that, again, we just started to think about and play with. But what you have is, patient name, their date of birth or age, right? Emergency contact, their relation, and that emergency contact's phone number. Why is that important? You may forget a question. You may not get the right information. Stroke team may want to confirm something. So we're going to put down that person's name who's giving us the information. More than likely, our stroke patient can't talk. In most cases, a family member reports the stroke. So we need their phone number and we need their relationship and name, obviously, right? Last known good, really important, right? So when was this patient last normal? When did you last talk to them? When were they last involved with you? Blah, blah, blah. If we can't get last known good because the stroke is a wake-up stroke, right? They went to bed, they were fine. Now they woke up and they have a stroke. When was the patient last seen healthy, right? So was it at dinner last night? When did you last see them? And then obviously on a wake-up stroke, and you could have different situations here. Somebody can go shopping, they come back an hour later, 2 hours later, they find their loved one had a stroke. So when did you go shopping? What time was that? A wake-up stroke, we want to know when was the last time they were seen healthy. Well, around 5 o'clock, I think they were fine. And around 6, they started complaining of some indigestion, and they had a little bit of chest pain, but it didn't seem like a big deal. Well, that chest pain could be indicative of a stroke being shot off by AFib. So we need to know also if they woke up with the symptoms, how long were they asleep? When did they go to sleep? And when was the patient found? Well, they went to bed at 8. And I saw them this morning at 9. Okay. So we just fill that out. Pertinent medical history. Again, we're not going to spend a lot of time getting every last detail, right? We can get further details, or the stroke team can get further details because you're providing them with the contact information downstream. So big things we need to know, and some of this should now start to make sense given on the information we covered on the types of strokes, and the treatments, right? And some of the contraindications. So are they on anticoagulants or blood thinners? And have they taken them in the last 72 hours? Now, some protocols may change that to 24, 48, 72. You just blanket it in the last 72 hours. What are they on? Have they taken their meds in the last 72? Because you may find out Well, I haven't given them my meds. I didn't give them. They did take one yesterday, but I didn't take them any. I didn't give them, Xarelto today. So you circle yes if they have. Circle no if they don't have blood thinners, anticoagulants, and in the line in between the yes and the no, you write down what they took the last time and the dosage if you can. Does the patient have any medication or clinical allergies, right? We need to know that. They have contrast issues, dye issues. We're going to be doing imaging studies. We need to figure out what do they have. So that's why clinical allergies are important. Medication allergies obviously are always important. Yes, no, line in between, write down what it is. You can always say see on back. So you can flip this paper over and write stuff down on the back if you don't have enough room on the front. Does the patient have cardiac history or recent surgery? Again, we need to know any recent surgery, cardiac history. You could probably add in there trauma, right? Any kind of trauma. But we're just mostly ensuring to figure out, like, are they a victim of AFib? Have they had any kind of, surgery that could have thrown off a clot? Yes, no, line in the middle. Write down what happened and when. Then we're going to get into our BFAST assessment, right? We're going to, is their balance impaired? Do they have an eye gaze or drooping, facial drooping? Is there any arm weakness, speech difficulties? Are they having a terrible headache? Did they complain of a headache before this occurred? And lock state. Yes or no, right? Circle the appropriate answer, line in between, write your findings. Left side eye gaze, or left eye gaze, or eye gaze to the left, or right side drooping of face, right side of facial drooping. So write down what you have. Again, you can write down C on back or continued on back or whatever you need to give more notes. The idea here is anything in red is critical, and if it's circled, it draws the attention of the stroke team. LVO assessment. This is where we're doing a specific, this is the BFAST, the plus side of BFAST, right? Where we're kind of trying to figure out, do we have a large vessel occlusion? And what we found is if you can measure the amount of time somebody can hold up their legs and arms, gives a higher indication as to if they're having an LVO incident. So in this case, what we want to see is you're going to raise somebody's arm, ask them to hold it there, and you're going to count to 10, right? 1,000, 2, 1,000, 3, 1,000, right? And if wherever they drop their arm or their arm starts drifting, that's where you stop counting. They go above 10, good news. If they're below 10, right, 0, 3 to 5, 0 meaning they can't do it at all, immediately drops upon you raising it, 3 to 5 seconds, 5 to 10, whatever it is, circle that appropriate indicator for both the left arm, left leg, right leg. So you're going to do all of this, the BFAST and the LVO assessment on every stroke, right? TIA, non-TIA, any one of them, you're going to find your findings. The right-hand side here, you see the EMS protocol, just to remind you, move, evaluate, gather, prepare, intercept, and notify. This document, very important, is going to be handed to the stroke team or handed to a paramedic unit when they intercept, or handed to medevac if you're doing intercepts, right? So this is kind of a really good way for you to remember what you need to do and gather all the right information, and also have this tool that you can give the definitive care, the upstream care, so they kind of understand what was done and the information, okay? So hopefully that is very helpful. And I'm going to show you a quick video. This comes from the American Stroke Association. I like this video and I hate this video. I hate this video. I think this video is a great video to use as kind of a, what's the right word? A learning kind of, I don't know. The first part of the video, let me explain to you. This is a simulation of somebody having a stroke, and you're going to see EMS arrive. My view of life is this violates our protocol that we just talked about. They're not moving this patient soon enough. You'll see in the video they're spending a lot of time on scene. They are stopping to take a blood pressure. My view is you can do all that in the rig. Right, you can do that in your office. You can get the blood pressure. You can finish interviewing the person, the family member as you're walking out. Get this person into your office, especially if they crash. Right, if they crash, you're better off with them in your office than not. And second of all, once they're in your ambulance, you're in a better controlled environment. So that's the one critique I'd have on this video is get the assessments done in the ambulance, not bedside in somebody's home. Get them moving. The rest of the video outside of that, I think, is really great because it gives you a visual understanding of the treatment of stroke, and kind of how everything you do, how that factors into the decisions the stroke team can make, and ultimately what the neurosurgical neuroradiologists can do. Okay, so let's watch this video and then we'll wrap up.
Steve, honey, are you okay? Can you speak? Because your face is kind of fallen. Can you lift your arm? Can you lift this arm? This one? Okay. I think you might be having a stroke. I'm going to call 911.
Ambulance, AMR. What happened?
Well, I came out of the bathroom and I just noticed that his face was kind of drooping.
Yeah.
And I asked him if he could speak. And
Okay.
He just can't
Okay.
really. He's just kind of moaning.
Okay.
And then I checked his arm and so I called 911.
That was a good thing to do. When did you last see him normally?
Well, we went to bed 11:30 last night.
All
He
right.
was fine.
Okay, totally fine.
Yeah.
Okay, so it's 6 o'clock in the morning, and you just found him. He woke up like this.
Yeah.
Well, based on your husband's presentation as it is right now,
Yeah.
I think that we should take him to a comprehensive stroke center.
Oh, we got an alert. Stroke alert activated.
All right, what's gonna happen is when we get there, we're gonna take you out of the ambulance, and then we are gonna talk to the doctors and the nurses, and then they'll probably take us straight to CT scan. Hello. All right. This is Mr. McAllister, Stephen. He is 62. He went to bed around 2300 last night. Woke up this morning, his wife found him 6 o'clock in the morning with right-sided deficit, right-sided facial droop, and not really talking. He can kind of say yes and no, but kind of groans. Okay, let's get him to CAT scan.
Can you raise your arm for me? Good. Squeeze my hand real tight. Now try to raise this one for me.
Is everybody ready?
Yeah. 1, 2, 3.
So his NIH stroke scale is 24 at this point. He's a wake-up stroke. He won't qualify for IVTPA, but he probably will be a good candidate for thrombectomy. Let's call the interventional team right now. Right, so his CT without contrast has been completed. I can see a clot in the left middle cerebral artery.
Hello there, I'm Dr. Robinson. I'm a neuroradiologist, interventional neuroradiologist. As you know, your husband's having a major stroke. I'm sorry to meet you under these circumstances. This is a dire situation where minutes count. And so we're working very quickly to do everything we can for him and maybe try and restore blood flow to the brain. The imaging that we have so far and his neurologic exam indicates he's got complete blockage of the artery to the left side of his brain. That's why he can't use the right side of his body, why his face is droopy, why he's ignoring the right side of the body and is unable to talk. Fortunately, we have ways of treating these where we can, if we can act quickly, get up and pull that clot out and restore blood flow to the brain in many cases, and in many cases, restore neurologic function. We have Mr. Steve McAllister here for acute stroke intervention. Mr. McAllister had a wake-up stroke this morning. He's got a complete left MCA occlusion and a very high stroke scale of 24, and we're going to proceed to emergent angiography and hopefully thrombectomy. This is the Stentriever thrombectomy device, where once we have the catheter across the clot, we can put this out It restores flow by opening up the vessel and pushing the clot out of the way, and then after a period of time, we pull it back in and pull the clot out. We are ready for post-thrombectomy run. All right, here we have our initial run with complete blockage of the left middle cerebral artery and no blood flow to that left hemisphere, left middle cerebral artery, and then post-thrombectomy, and we show complete restoration of flow to the left middle cerebral artery. That's excellent. Hello there. We're all done with our angiogram, and it went very well. You did an excellent job by calling 911 and getting him into center that can treat this as soon as possible. I think you may have saved his life.
So hopefully this has been a helpful video for you to kind of give you some ideas on things that can be improved in terms of getting the patient moved and evaluate and gather information. And then also, obviously, getting a glimpse of how your decisions can make such a meaningful impact on someone's life when it comes to a stroke, and some of the simplest things. My hope is that we've kind of demystified some of the decision process in strokes and stroke evaluation. You can certainly use the stroke assessment template to help guide you in an actual situation. Some of the considerations related to transport, but most effectively, hopefully simplified also what type of stroke center you should go to. Again, you need to follow your own local protocols, but I think to simplify it down to TIA, primary, non-TIA, comprehensive, is a little bit simpler than trying to, on the fly, figure out exactly what type of stroke we have and how severe and that. In this video we just saw, actually, the patient did not qualify for TPA because they were a wake-up stroke, so comprehensive was really their only option. So hopefully, again, this has been very helpful for you. If you have feedback, please let me know. And with that, thank you so much for your time and attention.